we transform policies and commitments into real meaningful change in people's daily lives. Because we know that healthcare accessibility must move beyond just legislation and strategy documents to become a lived reality for every individual. So our panel, which is a very distinguished panel, will share insights, experiences, and practical approaches for turning vision into action. Moderating this very important conversation is Simran Main from Kenya, who is a passionate humanitarian and public health advocate, actively serving with the Lions Club International Foundation and collaborating with the World Food Programme on initiatives that improve school feeding infrastructure and community well-being in Turkana County. She's also a respected researcher and co-author of studies examining the socioeconomic factors that influence chronic disease management in rural Kenya, bringing valuable insights at the intersection of health policy and community development. Please join me in welcoming our moderator, Simran, who will introduce the panelists for this session titled Healthcare Accessibility from Policy to Practice. Over to you, Simran.
Thank you, Som. Good morning, good afternoon, and good evening to the audience and everyone listening over. That was a really huge introduction, Som. Thank you very much. I will take this opportunity to introduce my panelists for the session. I will start with Dr. Majid. He is the Associate Dean for Research and Innovation at Strathmore University Business School and a senior lecturer with over 30 years of leadership experience in the healthcare sector in Kenya. His expertise does include healthcare management, strategy, quality improvement, operational excellence, and organizational change. But apart from this, Dr. Majid also holds a qualification in medicine, management, and law, including specialist medical training, an MBA, a DBA, and admission as an advocate of the High Court of Kenya. He is also a certified mediator, arbitrator, and executive coach. Dr. Majid has served on the board of trustees at Strathmore University Foundation and continues to contribute to the healthcare leadership and innovation. I also have Mumbi. Mumbi is the head of Global Inclusion World Food Programme. She leads initiatives to advance inclusive practices across global humanitarian operations with a strong focus on disability, inclusion, and accessible workplaces. She holds a background in psychology and a Master of Science in Organizational Development. She is highly recognized for translating inclusion policies into measurable organizational impact, and she champions leadership, accountability, and inclusive design. As a panelist of this summit, she will share her expertise on healthcare accessibility and inclusive systems, and above all, she credits her role as a mother with shaping her empathetic and purpose-driven leadership. Thirdly, I do have Patricia Mills. Patricia Mills is from Australia. She is a highly experienced registered nurse with an extensive career spanning rural and metropolitan healthcare in Australia. She has served in clinical, management, and executive nursing roles, including leading teams of over 115 nurses across multiple states before retiring in 2013. Since joining Lions, she has held numerous leadership positions, including district governor. She is a passionate advocate for community health, playing key roles in the Victorian Lions Skin Cancer Foundation and leading diabetes awareness initiatives across Lions Australia, while coordinating major health education programs nationally. Last but not least, I'd like to introduce Lions Sir Tony Benbow, who is an OEMGP in Australia. He is currently the third Vice International President of the Lions Clubs International, where he began his journey in 1985 as the charter member of the Lions Club of South Vermont, Australia. Over 4 decades of service, he has held various leadership roles, including zone chairperson, cabinet treasurer, vice district governor, amongst many others. The list is long, Tony. In July 2025, he was elected the international vice president. But beyond that, Lion Tony has enjoyed a distinguished 40-year career in Australia in the banking industry, serving in senior executive leadership positions. He's also chaired several Lions foundations, and him and his wife are progressive Melvin Jones Fellows, and they have received numerous rewards in recognition of their outstanding service to Lions and the community, including advocating for people with autism and the disabled within the community. So thank you for being on this panel. We totally appreciate this. I'm gonna start off with a icebreaker for all of you before we go on into our session. And please feel free to go first. From your experience in Australia, Kenya, and Italy, and the global humanitarian setting at large, in one sentence, what does patient-centered care mean to you? Dr. Majid, would you like
Particularly
to go
from my
first?
point of view. Yeah,
Go ahead.
I'll throw in for the first one. Thank you, Simran. I think, when we start to look at patient care, it's got to look at outcomes. And I think from our perspective, delivered care has to meet the patient's need. A simple but outcome that's got to have the priorities that we look at.
Thank you. Let me chip in from there. I agree with Tony 100%. We can add more to that. Patient-centered care, most of the time we look at it from the institutional point of view, and that tends to be a little bit paternalistic or paternalism type of approach. I think patient-centered care is from the patient point of view. When you look at the definition of highest attainable standard of health, acceptability is one of those measures. So it needs to be care that is acceptable to the patient, especially when you're talking about disability. That's my take on patient-centered care. Thank you.
And if I can chime in, because I'm coming in from a workplace perspective, for us, patient-centered care, whenever we are looking at our employees, means living our commitment as the World Food Program to leaving no one behind. So we ensure that people with disabilities shape access and benefit from their assistance with dignity and without barriers, because our work is solely on ensuring that whoever we are giving food assistance, their needs are met. So using an equity lens whenever we are having aid distribution. Thank you.
Patient-centered care means being able to everybody to be able to access care when they can, and I think regardless of whether they're disabled or not, I think that it's very, very necessary for people to be able to just access the care and and know where to access the care as well.
So Simran, allow me to just address this a little further. Picking from Sir Thomas's discussion, I really loved the discussion. We need to look at patient-centered care. That care does not start at the hospital. And that's where we tend to focus on the patient-centered care. And I feel that is missing opportunity. By the time the patient has fallen sick and is not able to get into that public transport, we've already missed on the patient-centeredness. When we have a wheelchair person heading to the hospital and the pavements are rough and with potholes, we've missed the opportunity for patient-centered care. So we need to look at patient-centered care in the continuum of care, in the ecosystem of care, and not just focus on hospital-based care. Thank you.
So building on to Dr. Majid, your question, you're basically saying accessibility needs to move beyond physical spaces. So what are the less visible barriers that patients with disabilities face when accessing healthcare?
Let me build on that then for just a few seconds. I think we need, first of all, one of the most visible barriers is to move beyond just physical disability. When we have an patient suffering or patient with albinism, the sunlight, especially being in an African country, is already hindering that access to care. So we need to look at it from 360 degrees of the person with disability. Now, even in some countries, even my bald patch would be considered disabled because I would get kidnapped and somebody opens up my skull to look for gold. See, so we need to look at it from that point of view. It sounds light until it happens to you, because this happened in one of the East African countries. So if we to look at disability, physical, environmental, and we begin to see that I think our own how do I say, myopic approach to disability is one of the biggest hindrances to availing care to the disabled. Thank you.
Mumbi, would you like to add on to that?
Yeah, I'd just like to add, based on an employee perspective, because WFP works in over 123 countries and territories across the world. One of the things we've seen, because we work in the most challenging contexts in the world, is stigma. And this stigma is based on those operating contexts, because what we see is that in the like was said earlier, most of the people who have disabilities live in the developing countries, right? And that is where we operate. So we find that that stigma makes people not go and seek any help whenever they have disabilities. And also what we've seen, and from my personal experience, is systems are not designed with diverse needs in mind. So which can leave employees navigating care on their own, right? So they don't have a support system where they can go seek that care. So the way we build in a world that is built not having people with disabilities in mind can often lead to them navigating those spaces by themselves. So from an organizational perspective is, what is it that we can do to ensure that the people that we say people are our most important resource. So how do we ensure that the people who are our most important resource are serving the people that we serve? How are they going to be able to serve the slate of needs that we are assisting out there? So ensuring that we reduce the stigma, and also building and designing the systems with everyone in mind. That is what we've seen can mitigate the barriers that we often see. Over.
Thank you. Tony, Pat, is there anything you'd like to add based on your expertise?
I think, sorry, Pat, go ahead.
No, you're right, Tony, go.
I was just going to say, I think I, confer completely with Dr. Majib in terms of that process and the understanding, and as what Mumbai said is really critical. It's got to look at the individual, and it's got to look at the resource available to it. We can't have that stigma that goes with it. It's got to be much broader than it, and it has got to look at it as being, fully encompassing when we look at the support that's needed. Thank you.
No, I think I agree with everything that everybody said, and I think accessibility is probably one of the most important things that we have to have. And I think listening to our keynote speaker, who spoke quite a lot on accessibility and being able to get into places and having ramps available and all of those sort of things. And I think that really, really is very, very important to people to be able to access and be able to go to places where they need to be going to. And I think I'm just most impressed with you talking about stigma. I think that we're working with that at the moment, and I think that's something I think that really needs to be brought to the forefront more. And I think congratulate you for bringing that up, because that is sensational.
Thanks. Thanks, Patricia. So I now want to move on to the essence and the core of our session today, which is moving from policy to practice and advocating for this. And I just want us to spend a bit of time on this with all your expertise, where each of you as panelists come from various countries and sectors, and a lot of countries and organizations do have policies that support inclusive healthcare. But from your various perspectives, why do implementation gaps persist, and how do we bridge the divide between policy and everyday practice?
So from what I see, and obviously because I'm looking at this from an employee perspective, and I was just listening to everyone's credentials and I was like, wow, this is amazing. However, I think why these implementation gaps exist, and actually even from what we do, number one is because we don't involve the persons with disabilities. So whenever we are making decisions, or we are, for myself in my organization, whenever these policies being drawn or reviewed, you're not including. We don't often think about the diverse slate of people we have, of employees. So if you don't include persons with disabilities in the policy, you're more often going to find that there's gaps in implementation, because number one, they're not involved. So whatever you're implementing is not catering to them. And secondly, there's a lack of awareness. The world was built for people who the world calls normal, and I'm saying normal in quotes, right? So it wasn't built for everybody. Whenever we are thinking about the various dimensions of diversity, thus implementation gaps will exist. And also a fragmented approach in terms of inclusion. So when we think about diversity and inclusion, more often than not, people will look at the gender aspect, right? Male, female. We are not thinking about the intersectionality of the various other aspects, whether it's people with disabilities, people who are LGBTIQ+, all the dimensions of diversity, we don't look at that. And specifically, if we are not looking at persons with disabilities, then we are not going to build a world that caters to both the non-apparent and apparent disabilities. So in our case, it's as an organization, me as leading the global inclusion is a true focus on where is it that we are missing out? Where are we not including every single person? If at all, inclusion is one of our values, by the way. So if at all we are going to truly come away as an organization that's inclusive, where are we missing the mark and how can we do better? So I think those are some of the gaps that I've seen from my own experience. Over.
I was going to say that in our area within Lions, in the area where I am in Victoria, we have an All Abilities Lions Club. Now, when we started this Lions Club, a lot of the people who joined us on the spectrum, and they were very markedly not being able to do the things that they could do. We sort of said to them, it's all about your ability, not about your disability. So we've seen a growth in the people who have joined the Lions Club, and what we've been able to do for the people who are on the spectrum. It's been absolutely amazing what we've been able to do to enable them to actually get jobs. One person recently has been promoted in his work, and I think that I was talking about it before. It was about accessibility, and I think this is the thing that we need to do. We need to encourage people to get out there, and we need to encourage people to join in with what we're doing, and we want people to say, what can we do to help you? And I think that's really, really important.
When we are looking at involvement of people with disability in decision making, I want to challenge that we go further than that. We need to look at the entirety of the ecosystem in dealing with any type of disability. We need to look not just at the patient who comes to the hospital who is disabled, but the person who also takes care of that disabled person. And their points of views also needs to be taken into consideration when you're translating policy to action. What do I mean by this? When a nurse is struggling to lift the patient from a wheelchair onto the bedside for examination or to the stretcher, that means that particular design is not appropriate. So if we don't listen to that nurse and saying she is having a problem, so we need to look at the entirety, and everybody needs to contribute to it. So I agree 100%. The voice of the disabled is absolutely important, but so is the voice of the entire ecosystem. So we need to look at that. Then also the comprehensiveness of the definition of disability, I feel, is contributing to the lack of progression of from policy to action. By this, I mean, we don't see, whenever we talk about disability, the first picture that comes to mind is physical disability. But we do have a big spectrum of disability that requires to be taken care of. Can you imagine a blind person giving consent for surgery? How do they sign the consent? So if we don't think of it, how do we deal with a patient with autism who requires reduced sensory input for them to become so that they can make a reasoned decision? How do we reduce that patient, remove them from a very noisy casualty environment or accident and emergency environment? So unless we think of it holistically, in Kenya, we have excellent policies. We have excellent laws. One of the biggest things that retard progression from policy to action is this statement of progressive realization, that we are not able to do everything in one go, so let's do it progressively, which is a synonym of doing nothing. So we need to then set out the specific milestone of what progressive realization is. Progressive realization has to move from 1 to 2, 2 to 3, 3 to 4. We cannot use progressive realization as a reason for doing nothing. It's very Kenyan specific because that's the environment I'm aware of, but we've been using this repeatedly. No, we can't realize this because we are still working on it. 20 years later, we are still working on it. Thank you.
And I think also too, when we start to look at things, and I can say from a local perspective, and Pat can comment here as well, we find that the system drives the outcome, not the individuals and the support processes behind the individual needing the help and the assistance. It's a reverse process. We've got to try and change it to become much more, if you like to call it, patient focused, not system focused. Whereas the system is too designed to, well, if you fit into this box or this box or this box, that's what you're going to get. We've got to change that attitude. And I don't know where that fits in other areas of the world, but from a local perspective, it becomes very system driven, not looking very much on an individual patient basis and adapting the needs and the qualities that are needed to assist those individuals. And that, potentially, in terms of organisations going forward, is where potentially we may have an opportunity at the community level or organisational level to try and have influence. Thank you.
That just leads up to my next question of who bears the greatest responsibility for ensuring that these policies actually translate into action. And you've kind of just answered that to a certain extent, Tony. Mumbi, in your part of the world and in your organization, because you look at it from a workplace perspective, how does the UN or the World Food Programme or your organization actually bear up this responsibility? And is it a collective responsibility? How does this work?
Thank you, Simran. And I'm going to just respond to that based on what Dr. Majid has said. So for us, because we need the policy guidance, right? And you've said about, some things remaining as, you have to progress in order to progress. So for us, we are guided by the United Nations Disability Inclusion Strategy. And this is a document where there's various performance indicators and various business owners own particular indicators. For example, I own all the performance indicators to do with reasonable accommodation, employment of persons with disabilities, and capacity development of those. So there is what I've seen to be totally useful and what makes sure that we are doing what we ought to do is those performance indicators are graded. So you're either approaching, you're meeting, or you're exceeding. So every year there's the organizations, all the United Nations entities, funds, programs, they are graded on that. So whenever there's guidance from the Secretariat, unfortunately, sometimes people need that push, then you find that all the organizations are going to participate and they're going to move towards ensuring we have disability inclusion and that it's everyone's responsibility. What helps us also is a management that is very bought into what we are doing in terms of inclusion. So I could go straight to the executive director, the deputy executive director, and say, I need us to do A, B, C, D so that we can be more inclusive. So inclusion is not just performative for us. It's something that we absolutely uphold. It's one of our values. We have inclusion, commitment, humanity, and the rest. Therefore, we don't want it to just be a placard on a wall. It's something that we practice every single day. And if it has to do with me, obviously, I'm very passionate about it, not just because it's a job, it's something I care about. And also setting aside budgets for this work is critically important. And that's what we've done. We have a centralized approach to disability inclusion where, because we work in all these countries and each country is basically, the country director is a CEO of their country. Sometimes you don't have funds facilitate disability inclusion. So I hold a budget in headquarters so that this is accessible to everyone equitably. So there's no country that's going to say, we don't have funds for this. So it's a centralized approach. I can speak a lot about it, but I'm going to give the other panelists an opportunity. If I start, I'm passionate about it, I could speak all afternoon, but we don't have all that time. So thank you, Simran. I appreciate it.
Thank you, Mubi. Dr. Majid, from a Kenya perspective, what would you say in terms of bearing the greatest responsibility? Is this a collective decision? I know you mentioned that it's not just about the patient, it's also about the carer. But what else? What about the governments? What about development partners and communities like Tony mentioned? Or are we looking at all of them?
Yeah, the last word you mentioned is what I firmly believe in. We're actually looking at all of them, and we need to be responsible at individual level and therefore at community level. I'm using the word therefore deliberately because there is no community without an individual. So when we say, is it responsibility of the government? But the government is us. So we need to hold our government accountable, and we need to discuss this. I want to be a little bit utopian, a little bit idealistic, and say if we remove standards and say the minimum standard is for a building, the roadside, for the vehicles to be able to accommodate the disabled person, we would automatically have met the standards for everybody else. So you can imagine if the building, we are able to have the physically disabled, the visually impaired, the hearing impaired standards already included as minimum standards, then there would be no other standards because we would have surpassed every other standard. But if we set the others normal standards and then have an inclusion as an added on, I feel that would limit. But I appreciate I'm being utopian. But for me, it sets the tone that it's all our responsibility to have standards that are inclusive as a normality. That's our way of life rather than as beyond and above. Thank you.
Pat, thanks, Dr. Majid. Pat, do you have anything to add?
Probably nothing to add, but I want to reinforce exactly what Dr. Majid said and Tani has said about community. I think it's exceptionally important that the community has a big handle in, if you like, setting up processes, if you like, and letting people know and making people aware of what the people who have got the disabilities, making people aware, letting people know exactly what is happening to them, because people just don't know some of the time. And what we were talking about before was about the carers. And I think that's really, really important for people to understand that the carers are a priority with a lot of these people. And we have to take into account that the carers are affected markedly by what they're doing with the people in their community. But I think community is a major part of what we have to, and communities have to make everybody understand what is happening in their community.
Absolutely. So when we make a call to action, what can we actually do? Because based on your various experiences, what is the one practical action that healthcare institutions, policymakers, humanitarian organizations, or like we've been talking about the community groups, such as Rotary itself, what should be prioritized in advance? And especially when we look at the theme of the summit, nothing about us without us, as far as even patient-centered care is concerned. How do we look at this as being fully accessible care?
Maybe I can just go because I really like what Dr. Majid was saying and what Pat said. The number one thing that we can do is universal accessibility. Whenever you are talking about, sometimes, we don't have to, there's something you said, Dr. Majid, that made me remember about what we do in our context. So universal accessibility will not only help the person who is a wheelchair user, for example, So because we are working, as I said, in all these contexts, there's lots of buildings that we have. So ensuring that the building, for example, is already accessible before anyone ever is recruited that has a disability, that's one of the things we can proactively do to ensure that persons with disabilities access all our spaces. The other thing based on that is just reduction of stigma, because there's a lot of stigma around disabilities because, for example, because we work in Africa, there's all manner of things that are, there's connotations of why someone is disabled. So stigma reduction and building, having the universal design and accessibility whenever we are building, those are some of the things I see we can practically and tangibly do. Over.
Thanks, Mombi.
I think individual responsibility. I like what Rotary Lions are doing. You're not sitting back and saying it's government's responsibility. And Rotary is made up of individuals. Lions is made up of individuals who come together to make a difference. So for me, I think what the rallying call should be, we all need to take responsibility for our action. And the starting point is education. I mean, just what Sir Thomas talked about today was mind-blowing, and it allowed me to reflect a little more deeply. If we could have more of those kind of things, and I consider myself fairly educated and fairly liberal, and yet I was blown out of my mind. Now, you can imagine how much more this will have an impact across the country, from the rural woman in the village all the way to the boardroom CEO type of person. So the entire spectrum requires to be educated on what it is all about. I think with education, hopefully, and I'm saying hopefully, we can then change attitude. And if we can change attitude that disability is all our responsibility and we are all inclusive, then hopefully we start being more responsive and more considerate whenever we are designing facilities, education, hospitals, healthcare, you name it. Then it flows from there. Thank you.
Thank you, Dr. Majid.
What I was on my mind talking about inclusivity, and I think that what you just said, Majid, was just absolutely sensational, because I think we must be inclusive at all times and inclusive of everybody. And I think that's what we're noticing in our communities, that the inclusivity is actually producing wonderful results from all sorts of people. I work with a lot of people who are deaf, got cochlear ear implants. I'm working with Vision Australia. We're doing a lot of work with Vision Australia at the moment. We're making sure that they're included in everything that we do. And so that's, I think, yes, absolutely, inclusivity, and making sure that people are aware that they can, not that they can't, that they can.
And just to add a little bit to what Pat has said too, what we've seen here in Australia, particularly, that community and the community voice has had significant impact on changing how things are done. We made comment before about accessibility, the building industries and so forth. There are now very specific codes here in Australia that any new development or remodeling or thereabouts must have accessibility requirements built in. If it doesn't hit there, it does not happen. So it's been the community base and the force of a community saying we need to make sure that we can adapt has seen significant change, particularly over the last few years in that area. And it's only because of the local and at the grassroots level that we've seen impact that is impacted right throughout the industry itself, to make sure that our disabled and others have the accessibility to wherever they need to go. And that will continually happen now in the way that it's structured here. Thank you.
Simran, let
Thank
me
you.
just pick up
Yes,
on
go
what
ahead,
Tony and
Doctor.
Patricia are saying. I really love that angle of community, and I think there's a deep learnings there for especially people who are living in Kenya. But I want to take it further. I believe community is the picture made up of jigsaw puzzle pieces, that in that community there is the individual, and we need to get that individual to contribute to that community so that that community voice is an amplification of each one of our voices. So I really take that very to heart, what Patricia and Tony are saying about the community. And I want to take it further and say, let's build that community one person at a time. If we can get a critical mass of those individuals, and that's what then makes the community. Thank you.
Thank you. Mobi, do you have anything else to add?
No, just to say that based on what everybody has said, it's making sure that inclusion is not only my responsibility as the global head of inclusion, it's every single person's responsibility. And what I've seen to be really helpful is what I was saying, using the CRPD and also the United Nations Disability Inclusion Strategy, that has helped bring a lot of our colleagues together. So whether it's procurement, ensuring that what Tony was just saying, that the buildings are first of all accessible. The procurement that we are doing is accessible, just educating a whole group of people around disability inclusion. That has totally worked and will continue to be the vision where we'll see everybody included and no one is left behind, because that's one of our mottos. No one's left behind, and it's the same, I know, for this for the symposium, for the summit. Really, those are the things that will make sure that everybody is included, and that we remove any barriers for people with disabilities and not see them as people who we have to do something for. It's removing the barrier so that everybody can participate at an equal playing field. Thank you.
Thank you. So if we were to summarize this and talk about healthcare, how would you complete the sentence and say healthcare becomes truly patient-centered care when? So in the context of people with disabilities and accessibility and moving from policy to practice, how would you complete this sentence?
Mm. Yeah, I'll throw my 10 cents worth in at this stage and say I think when you look at it, you start to look at the outcome from the patient's perspective. The fact that if we have achieved what we want, the patient doesn't have to ask for additional support or help. We've achieved it because we have been able to deliver for that individual person, whatever their disability may be. We have already looked at it and we've delivered it without them having to ask.
Just reflecting on what Tony is saying, I think that's really deep. If you focus on the outcomes, patients don't go to hospital to get treatment. They go to hospital to solve a problem. So treatment is the path of solving that problem. So if we focus on the outcomes and why is it that they've gone to hospital, I think we will be able to address what patient-centered care is. Reflecting on Tony, I think that's a really deep, very deep statement. And I think that really captures it very beautifully. Thank you.
So Simran, from an employee perspective, because for us, when you're thinking about my colleagues who might take care of with disabilities, disabilities is not something we're going to treat, right? Respectfully to all the doctors, right? So there are some people who have permanent disabilities. So for us in the organization is using the human rights model for disability inclusion. And that means that we first don't see you as someone we don't see your disability first. We see you as a human being, and then as a person. And what we do is we understand what barriers are you facing to participate equally than other people who don't have a disability. And that's where then our reasonable accommodations process comes in. So we have a reasonable accommodation policy in the organization where anybody in the organization, whether you're a candidate, whether you're an employee or you recently have a disability, you can tap into the accommodation that you require to remove the barrier that you may be facing to participate equally. So if you're visually impaired, do we have screen readers for you? If at all you're autistic, we buy you noise cancelling headsets so that you can remove the barrier that we are facing. So for us is basically how we approach disability inclusion is beyond the label. So we don't see your disability. We first see you as a person who happens to have a disability. Thank you.
Pat.
And I'll go right back to what I was saying before. It's all about inclusivity, isn't it? Inclusive and exactly by what you were saying there, treat everybody as an individual, and then we look at the disability and see what we can do to help them. But we treat them as a person and as a personality. And I think that when you're working with, I've worked with a lot of people on the spectrum, and when you're working with them, they're all individuals and they're all different and they all have different needs. Some need the noise cancelling, some others don't need the noise cancelling. Some of them just want to play games on the computer, and that's okay as well. Others want to work, and that's okay as well. Let's find them a job. And one of the I don't know whether anyone knows that what next weekend in Melbourne in Australia, we've got 150 vision impaired and blind people going to drive a car around a raceway because we're giving them the ability to do that. And what they're saying to us is, we just want to be normal for one day. Let us drive a car. So they are going to drive a car around a raceway, and they are just so excited about it. But we've got to be able to treat people, you're right, as individuals, and that's what we have to do as a person. But yeah, we have to treat them right from home right through when they have to go into the hospital, if they need to go into hospital. Some people don't need to go into hospital. Some people don't need that, but they just need the care. And I will emphasise once again, I think we all have to look after the carers as well. And I think the carers are as important.
So, Simran, I really love what's being discussed. Two things that come to me that I just want to ruminate what Mumbi and Patricia have said. Mumbi's approach, if we remove the barrier, so to speak, we actually then, you're not, for lack of better word, disabled anymore. So we bring you to that equity. I think that's very powerful. Patricia's comment made me reflect. There is actually a judge of the High Court in Kenya who's an avid golfer, and he's visually impaired. In fact, he's completely blind. He can't see at all. And he's actually one of the best judges, I dare say. And he's a very avid golfer and very, very good golfer at that. So it goes to show exactly what Patricia is saying. You do what you want to do and what you are able to do, rather than people telling you what you cannot do. I love that. Thank you.
You, Dr. Majid. Tony, Mumbi, anything that you'd like to add to that?
I think from the respect of the panel there has summed it up beautifully. We're talking respect, we're talking opportunity, and we're talking recognition and treating individuals as they are.
And just to add to what Patricia was saying, this is so important, especially when we are looking at the reasonable accommodation. Two of us could have the exact same disability, but we require totally different interventions. And that's why for us as an organization, we don't even prescribe anything. Even in terms of what disability is, we don't put a list of these are the disabilities that we're going to focus on. If you have any disabling factor, you come to us. You know exactly, the people who have disabilities know exactly what they need. So for me, it's just to enable that process to take place. You have this disability, this is what you need, you know it, and my work is to facilitate that, no questions asked, making sure that, we leave that really, the power is in your hands to tell us exactly what you need. And for us, it's to remove those barriers. So I was just reiterating what Patricia was saying earlier. Thank you.
Thank you. I think, do we have any questions from the audience? Sam, for if there's anything that the panel would like to answer.
My name is John. Excellent panel. How far are disabilities in the Global South incorporated in the country's public health services? Neglected diseases causing disabilities are all in the Global South.
That's a very deep question because it's an intersection of multiple issues. Neglected tropical diseases, there's a reason why they're neglected is because we don't think they make any money at all, if we're to be honest. So we need to, like any doctor, diagnosis before treatment. Then we add on top of that as a cause of disability, but also as a consequence of disability. So you can imagine a patient with leishmaniasis or that causes severe disability, cutaneous leishmaniasis or visceral leishmaniasis. So you can begin to see that we need to also take responsible. I'm not a fan of taking the begging bowl to the Western world and looking for solutions when we can undertake solutions ourselves. If we can bring like-minded people, I may not have a solution, but myself seated with Simran and seated with Patricia, together we can come up with solution building on each other. So I think we need to look at those conditions like neglected tropical disease and ask who is neglecting them.
Yeah.
And if we can answer that, then we'll see that yes, other people can neglect them, but why are we also neglecting them? So then the responsibility is actually on us. Thank you.
Thank you. I've had the opportunity personally to interact with organizations that deal with neglected tropical diseases as a Rotarian, and we are working on a project around West Pokot, Ugandan border. So the way I look at it is that it's up to us, as you have said, Majid. If government is not doing it, I'm a Rotarian, I'm here, Simran is a Lion, she's there. So what are we going to do about it? Partner with the organizations that have already done the research. They have some of the solutions, or we come in and help them with the research, then come up with a solution, because it takes about 10 years to actually get something going around that. So, and I think when we say Global South, it's too broad. I find some of these things are based on a country by country situation. Some countries are advanced when they're dealing with some of these things. Other countries are still a bit backward. They're still dealing with issues of basic needs. So it's quite a broad question, but the challenge is to all of us to take it up. There's a question.
We need to go further. Sorry, just to add on that, we need to go further because the whole concept of citizen scientist is now very, very prominent. Let's not be paternalistic either when we are dealing with this, especially with that intersectionality of disability and neglected tropical diseases. We need to involve the people themselves. Snake bites is considered a neglected tropical disease, but it's not everywhere. It's in a particular area. So you have different conditions at different areas. So if we involve the people there themselves in coming up with our solutions, the same way we are saying, let's involve the people with disability, and not just the people with disability, but the entire ecosystem. So similarly, let's involve everybody in the entire ecosystem in dealing with this. Thank you.
Thank you. There's a question here from somebody called Zoom user. So he says diagnosis is a big issue in our country. Is it medical ignorance? I'm not sure what country the Zoom user is from, but I don't know. Any one of you can answer on behalf of whichever country you imagine diagnosis is a big issue.
Let me start from Kenyan point of view. This is my personal belief that all our patients seek medical care very, very early. That sounds a bit contradictory to what has been published, but they get appropriate medical care very, very late. As a nephrologist, one of my biggest frustration was I wish the patient had come to me 6 months earlier. We could have saved this patient. But guess what? The patient did go to a clinical person 6 months ago, but was referred to the right person very late. So when we're looking at it, it's not at the individual level. We need to look at the entire ecosystem of healthcare. And I believe the SDG 3, then universal healthcare, and focusing more on preventive and promotive rather than curative and rehabilitative would probably go a much longer way. And that would be a biggest bang for your buck, so to speak. So we need to look at it in totality as well. Thank you.
Another question from Zoom user. Policies never reach the lower income population. What do you have to say about that?
It's all about education and being once again talking about accessibility and people to be able to access that the medical care. I really don't know what the answer is there at all, but I think maybe we've got to have more accessibility for people so that they can understand what is available and where it is available. And I think one of the other things that one of my mantras is we have to give people up-to-date information as to what is happening. And I think I agree with you, Margie. You know, sometimes it's too late. People just can't get to care as quickly as they would like to. Sometimes it's because they haven't got the wherewithal to actually get to where they need to be. And I think that that's a real problem. And unless and until we can solve those issues, I don't know what more we can do.
There's another disease that I've come across, and both in medicine and in law, and this is a disease called poverty, which is very distressing because you know exactly what needs to be done, but the patient cannot afford to do it. I mean, very distressing. A patient had something very treatable, had straightforward malaria, but could only afford one dose of the medicine. Now, what happens there? So it's a societal problem, and I think we need to be our brothers and sisters' keeper.
Yeah. There's no easy solution to that.
Also ignorance sometimes, so that such that people go for like they go for late, what do you call it? By the time you're checked, it's a bit too late for you to get treatment, and you're just being one of those.
But you need to look at it broader. I give an example where a woman did refuse to go for breast examination, even when she knew there was a lump in her breast, because she was worried if that lump is found, that the husband will run away and will get married to somebody else. So unless you address those societal issues as well, so it's not as simple and straightforward. So we need to look at it holistically, that if we don't address this societal misguidance and how do I put it? Dependencies. If that woman was financially dependent, it would not be worried about the husband running away. She would probably have sorted medical care much earlier. So for me, it's a lot of intersectionality. And as Patricia says, there's no easy solution to this, but we need to start picking at it and starting to break it down. Thank you.
Thank you, Majid. You just reminded me of a friend I lost about 3 years ago. She was diagnosed with breast cancer, but she didn't go for treatment because of religious concerns and restrictions. So she just braved through it painfully for maybe 4 or 5 years, and we watched her fade off, and she totally refused to go for treatment. So there are all those things coming up. There's a question here, a comment from Nusrat. She says, along community-based rehabilitation, implementing universal accessibility guidelines is critical for creating inclusive communities. I encourage Rotary to promote these standards across its projects and partnerships so that accessibility becomes a core principle rather than an afterthought. Really, really well said. Do you want to say something, Patricia? Did I hear?
No, I think it's all about accessibility, and I think that's exactly what we've been speaking about for the whole session, isn't it? You know, it's being able to access the care, and people. And once again, I'll go back to the carers. You know, it's the carers being able to bring the clients in or bring the patients in, or you know, it's really, really difficult for people to sometimes know where to go. You know, I think that this is all a part of education and awareness, and inclusivity and everything that we've been talking about today. And I think that I congratulate everybody. It's been a fantastic session.
So there's a comment here also from Naleni. As a disability researcher and activist in Canada, I was struck by an experience while visiting London. My 83-year-old aunt, a retired nurse, was told her home visit had been cancelled because no healthcare professional was available. The next appointment offered was July 29th, almost 1 month later. Inclusive healthcare is about more than policy. It requires timely care that preserves the dignity and well-being of older adults and others who depend on community supports.
Absolutely. Absolutely, 100%. Absolutely, it's got to be able to help everybody, but how do we do that? Yeah.
So Ramu Kaladi says, being born in the Western world and living in the US, my whole life as a son of immigrants from the Eastern world, the Western world is not perfect. The Western world overgeneralizes the global South too much. How can we work together to help each other? Satoni, answer that.
Maybe that's Lions and Rotary working together.
Mm-hmm.
And I think also having such such summits together and representing the world, then that will kind of bridge the gap.
Mm-hmm. Satoni?
It is, I think, the comment, it is working together where we have organisations such as, the United Nations, the World Framework, Lions, Rotary, who have a voice and have a, how could you call it, a collective bargaining power, if you like, because of the members' voices across the world, working together. And every country is going to be different in how it is looked at, and that's always going to be an issue. But as a group, having a formalised approach to look at the support, the mechanisms behind it, how we as an organisation can build the profile of what needs to be done for those in our community with disabilities, may be a way that we look at it in the future, and use our influences from an organisational point of view to the other areas that need it. Government in many countries are the ones that provide the services. Do they provide the services that are really needed, or how about it? That may be a point that the voice of the community working together with others who are at the coalface of knowing what the needs are as we work together. Pat's right. We have a collective voice.
So John says, excellent answer, Dr. Twahir. Thank you. Faith, my name is Faith from Kenya, Nairobi. I am a friend and an aspiring Rotarian at the Rotary Club of Westlands, Nairobi. I'm privileged to have attended this webinar. It's so insightful and informative. As a disability champion and advocate, I'm looking forward to learn more about disability inclusion, accessibility, mainstreaming, and advocacy. Thank you. Those are all the questions so far, unless there's anything more, Simran.
I think I just want to appreciate all my panelists and their expertise, and thank you for bringing out your various perspectives in your various countries. It's been quite insightful. I think I just want to also echo the thoughts of everyone that we need to come together as a larger community. Doesn't matter, shape, size, where we're from, never matters, honestly. And then champion that we advocate for policies to be put into practice, especially for these communities that also are part of us. So I don't think I have anything else to add. I just want to say thank you very much, Som, as well, for hosting us, and to the panelists for being part of such a huge discussion and this summit. It's been a pleasure.
Thank you.
Thank you very
Thank
much.
you.
Thank you.
Thank you.
Thank you.
Thank you, Simran. Thank you, our panelists, Tony, Patricia, Mumbi, and Dr. Majid, for a very, very enlightening discussion.